as a biomarker in the biologics target IL-4 and IL-13, dupilumab, not to name it. And therefore, IgE is very important, for example, when we want to use opalumab. And this slide is not a biological one, that is simply a slide where people have done very simple things, that is to measure in the same time and the same patient both biomarkers. You see as to whether both are, there is a link, and as you can see, there is a link between the two of them. However, that link and that correlation is not perfect, and as you can see here, and now if I just put the two threshold, the one for phenol, and we know that for people having more than 25 ppb of phenol, we can consider that phenol is high. The same for the eosinophils. More than 3%, that eosinophils in the sputum can be considered as high, and therefore there are most of them where both biomarkers will be together high or together low, in other words, perfect correlation. However, there are people who have high eosinophils but low phenol, and there are people who have high phenol and low eosinophils. In other words, if you just use one of the two biomarkers, you will have the risk of disregarding or overlooking those who might be type 2 inflammation, but with just one type of the biomarker to be high and be low. So that is very simple, but that is something that now justifies the recommendation of using both of them. Not eosinophils or phenol, but eosinophils and phenol. And with that, now things are simple, but there is another thing that I have to share with you, that for both biomarkers, there is not one threshold, but there is two thresholds, a high one and a low one. For example, for phenol, high threshold will be over 50, and low threshold will be over 25. And under 25, you can say almost with certainty that there is no inflammation. And over 50, you can say with a lot of assurance that there will be inflammation. The same thing for eosinophils. Two threshold will be 150 and 300. And therefore, with the two, you can have 9 different subgroups. And this is the study where people have calculated the risk for having asthma. And those will be reflected with the color. Red color will be high risk, yellow color will be medium risk, and green color will be okay. There will be no risk at all. For the last part of my talk, I will say this: thresholds and thresholds. We, as a physician or as a clinician, we use to rely on threshold to diagnose disease. For example, for diabetes, you have to measure the glycemia, and then you will conclude that the patient will have high or low blood glucose level. And the same thing can be applied with phenol and eosinophils, can be applied for the majority of the patient, but there are cases where both biomarkers will be questioned, as they are not able to be very useful for the clinician. And I will try to share those information based on this paper, which I found very important, and that has been published last year. And the authors of that paper has done something very simple. They have managed to convince the different drug companies that have sponsored all those RCT publishing the best journals in the Lancet, and they just say that we are not interested to see the patients who have been treated with the active drug. We are just interested to look at the data from the patients who have been treated with placebo. There are no damaging drugs. And from that, they were able to measure, and in all those trials, they have measured both phenol and eosinophils, and other biomarkers such as IgE, and they have followed those patients to see as to whether those biologics can have an impact on reducing exacerbation, on improving the health status or lung function. But here, what I'm going to show to you is not the effect of the drug. It is the natural history of those patients during those 6 months or 1 year of treatment with all those biologics. I found this idea absolutely fantastic. And that is why I just want to share with you, because it will give us some insights on how we should approach the patient in the clinics and using biologics in a reasonable and effective manner. And that is the first one. And there's just a few questions that I would like to share with you, and then I will conclude my talk. And the first one is as whether the measuring FeNO can have predictive value to predict the risk of asthma exacerbation. And as you can see here, the answer is yes, but it depends. It depends on what? It will depend on the severity of asthma as defined by GINA. For those colleagues who are not familiar with GINA, well, basically, GINA has decided that there are 5 steps from 1 to 5, and the higher will be the more severe in terms of symptoms. And as you can see, if you look at the level of FeNO, and for example, following those different curves in the x-axis, you can see that when you are in the green group, the yellow group, and even in the orange group, FeNO will be no use, because even that when you have more than 100 ppb, which is very high, when you have a very mild asthma, a change in FeNO will not help you to predict anything. However, if you are in the most severe group, that is to say, in the step 5 group, in that group in red, when you change from 25 to 50, you almost have increased significantly the risk of having exacerbation, and the higher the FeNO, the worse will be the situation. So, looking at the clinical symptoms is important. Second thing is not only the steps of GINA, but also on the history of the patient. If the patient in the preceding year, in the year before the study, has already 1 asthma attack in red, or no asthma attacks, the situation will be very different. With 1 asthma attack, you can see that FeNO will be more than important, is absolutely necessary. With no asthma attack, you might ask yourself as to whether it is really reasonable to measure FeNO regularly in those patients. The same thing for eosinophils. As you can see here, you have on the x-axis the level of eosinophils from 300 up to 1,000. And there again, that will depend on the lung function. When FEV1 is high, meaning that when you are in the green curve, eosinophils, even at the level of 1,000, which is very high, will not be very effective in predicting asthma exacerbation. In contrast, when FEV1 is low, meaning that lower than 50% in the red curve, there measuring eosinophils is very important. So just like that will depend on the other factors. And the same thing regarding the decline in lung function, measuring FEV1. And as you can see here, the measuring eosinophils can predict the future, the risk of having lung function decline if there is also an increase in FeNO, as you can see. When FeNO is very high, more than 50, and when eosinophils is also very high, the likelihood of having decline in lung function in the next year will also be very high. And therefore, measuring both biomarkers and depending on the clinical situation will give you valuable information in order to follow the patient and in order to be effective. IgE very quickly. We used to say that IgE is not very useful when we use that as a biomarker to follow the patient. Well, actually, that is not exactly true, because here we can see that in those patients with a history of nasal polyposis, well, actually, following those patients with total IgE can be of use, whereas without polypose, when actually IgE is no use as we used to say. And just to conclude with that slide, as a difficult one, and I just have two very quick summary slides. And therefore, if you use those with the same different 9 subgroups, well, depending on the clinics, in other words, was it asthma attack in last year? Yes or no? Or were they 2 or more clinical risk factors? And mostly, depending on the severity of asthma, the same value of both biomarkers will not give you the same risk, as shown with different types of score. When you are on the right, most will be red. When you are on the left, most will be green. And therefore, in those 2 groups of patients, maybe biomarker will not be useful, because those are well controlled, and those are very severe asthma. You are not going to wait for the result of the biomarker to start the treatment. However, when the patients are in that group, when the colors can change very easily, and that is why you must use those biomarkers to follow and to predict and to treat those patients. And that side you have already seen, and all what I want to say is we can now use very simply those 2 biomarkers as a proxy for this very complicated study. And in the future, maybe we will have other biomarkers, other way to approach this disease, and that future can be exemplified by this. For now, we are just here in the visible part of the iceberg with all those things that we are doing clinically in the daily manner. Now we can also access those parts which is not visible but accessible with the use of biomarker. And probably more work needs to be done to understand what types or what phenotypes or even more what endotypes those asthmatic patients actually belong to. And that is something which is necessary, because if now we have those medications which are already accessible, at least in Europe and in the States, and some of them are starting to be accessible here in Vietnam, in the next few years, the picture will be much more complicated, and with complicated things, we will need more subtle and more intelligent manner to approach this important and yet vital goal. I think.